Welcome back. For those of you who've not met myself or Rebecca before, my name is Les Jones. I'm a seating assessor with Careflex, and Rebecca is our clinical lead. I'll leave Rebecca do her own introductions in a second.
Thank you.
It's a little bit of a refresher session today. It's not quite back to basics, but it's looking at the foundations of specialist seating. And the presentation is split into two parts, really. One is a PowerPoint presentation with Rebecca. Secondly, we'll come back and we'll have a look at some of the basic principles of specialist seating with the chairs in the flesh here. So if I leave Rebecca wandering across to load up. Just to say that you'll get a copy of the presentation shortly after we finish, plus a link to share with colleagues who would like to see the presentation. So if Rebecca's ready, I'll just pass you across to her now, and I shall see you in about half an hour. Thank you.
Thank you, Les. Let's get this onto the full screen. Hopefully now that should be visible to everyone. As Les said, good afternoon, and thank you for joining us for our first webinar of 2026. Last year was a very busy one for us, being able to grow our educational programme, running more of these live webinars, and actually getting to spend a lot of time out on the road as well, meeting people face to face. That's all continuing into 2026. So just wanted to really highlight our newsletter. If you're not already signed up to it, keep an eye out for all the events that we have going on. Get in touch as well if there is a specific training need that your service may be looking for, whether that's virtual or face to face. Today's session, I've already kind of given you a brief intro, but getting it right in sitting, the foundations of specialist seating. It is kind of a back to basics session, but in the best sense of the phrase, not because postural care is basic, but because when things start to feel complicated, it's usually the fundamentals that make the biggest difference. Some of you may be new to specialist seating and looking to build confidence. Others may be doing this for some time and just want a chance to pause and reset and maybe sense check some of your clinical reasoning as well. Either way, the aim is that this session is useful to your clinical practice straight away. We'll spend a bit of time looking at the theory behind postural care and sitting, and then focus on how that translates into real world practice. The goal for me isn't to bombard you with more information, but hopefully provide a clearer framework that you can actually use. Those of you who have been to our webinars before might have noticed a bit of a different setup as well. We now have this more informative Q&A section that hopefully you have access to be able to kind of post your questions in there, just to make sure that we don't miss anything pertinent, and then we can answer those questions at the end of the session. So please do use that Q&A section, and Kiwi will be keeping you updated. Our colleague Kiwi's in the background keeping you updated as well through that section. I'm going to start with just a quick 2 truths and a lie. I don't need you to answer out loud, of course. I just want you to notice which statement do you instinctively agree with, maybe, or maybe feel most comfortable with. Body distortion and its secondary complications are inevitable. We should spend as much time on history taking as we do on the physical assessment. Repositioning is one of the most effective pressure care methods. What's interesting here isn't which one is the lie, I'll come back to that shortly, but what our instinctive reaction tells us about how we might prioritise risk, how that informs our decision making in practice. In seating and in the wider postural care, as clinicians, we tend to work under time pressures, of course, service pressures, competing risks, of course, the budget that might come into that. It's easy for certain assumptions to creep in about things like the inevitability, about what matters most in the assessment, and about where our interventions really have impact. And that's one thing, again, if you've been to our training days or to our webinars, one thing we like to do a lot is challenge assumptions and empower you to challenge those assumptions as well. For the record, the lie here is that body distortion is inevitable. It isn't, not when postural care is proactive, when it's well reasoned and properly supported. And that's exactly why today is a foundation session, because when assumptions do start to drive decisions, revisiting those first principles, those basic principles, helps us to recalibrate how we think, especially in sitting. Before we do get into the detail, I just want to acknowledge something that comes up a lot in practice as well. And when we've been out and about on the road, the discussions that we have with people, we are seeing an increase in awareness and appreciation for sitting support, but there are still barriers within our practice to that. Seating may be often treated as an easy option, a lower risk, a lower priority, something we come back to, a luxury item. And yet for many of the people that we support, sitting is where they spend the majority of their day and they load. And that's where that most important part of their care happens. When seating isn't quite right, the consequences are rarely dramatic in that moment. They're gradual, they're subtle, they're easy to normalise. Discomfort that becomes accepted, or that's just the way they are, that's just the way they usually sit, that's the way it's always been. Posture slowly adapts around that poor posture. Pressure risk starts to creep in under the radar. And by the time it becomes obvious, it's usually much harder for us to unpick. So the complexity and intensity of our practice worsens. So that's why, again, today is about foundations, not equipment first, not solutions first, but how we think about sitting, posture and support in the first place. If we get that right, everything that follows becomes more straightforward. It's also worth being clear about the scope of today's session. What I hope you'll see is not just what good seated support looks like, but how a postural framework can help you to understand why certain strategies are appropriate. We do only have an hour together. I do like to talk a lot, so this isn't designed to replace in-depth training or hands-on practice. If, as we go through the session, you recognise gaps or areas that you do want to develop further, that's exactly where our clinical study days come in, or longer training sessions. Our next ones, we got our clinical study days as part of our roadshows around the country. Our next ones in February are in North Wales and Manchester. I'm sure Kiwi will provide a link for that in the Q&A for you to see, and again through our newsletter, seeing where we are in the country. So by the end of the session, my aim is that you're more confident in a few key areas, understanding core principles that underpin postural care and specialist seating, being clear on how posture and load interact over time, and recognising what effective seated support looks like in everyday practice. If you leave with a clearer framework for assessing sitting and then a stronger rationale for the decisions that you're already making, then the session would have done its job. To make sense of sitting, we first need to acknowledge what the human body actually is. It's multi-segmental, it's highly flexible, it's inherently unstable, and sadly by that nature it does mean it's vulnerable to damage, especially with the individuals we work with who may already have damage to their body systems. To reduce that very complex system into something clinically usable, we can think of the body as a system of segments, and posture is simply the position of one or more of those segments in relation to one another, but also the orientation in space as well. And postural control isn't necessarily automatic, it's learned. We constantly respond to information coming in from things like our vision, our vestibular feedback, proprioceptive systems. So when any part of that system is affected, either through age, injury, illness, disease, think of the type of people that we work with, the ability to interpret and respond to that information changes. And that's when people start to struggle to achieve protective postures. Not because they're choosing not to, but because the system that they're relying on no longer gives them the feedback or the control that they need. So there are two main purposes of posture. First, of course, the obvious anti-gravity, providing enough rigidity to remain upright position against those gravitational forces. And the second, which often gets overlooked, especially talking as a physio here, is that interaction with the outside world. So being able to orientate the body segments so that we can eat and communicate and reach and engage and participate. That, as I said, that second purpose is often the one that gets overlooked in clinical settings, where Objectives maybe become more problem focused, but it is central to why sitting matters, and we'll come back to that throughout the session. Sitting loads multiple body segments simultaneously. Posture in sitting is never neutral and it's never truly static, even when it might look that way, especially with individuals that we work with. So when we talk about postural care in sitting, we're not talking about someone holding someone still in that perfect posture. We're talking about managing how a complex dynamic system copes with sustained load over time. And postural care in that context is the holistic use of any technique or intervention or management plan that we do within our clinical practice that helps to minimise postural abnormality whilst also supporting that functional element. And as I said, it's not about that static, neutral, aiming for perfection, because that's not always realistic, but more about preservation and, where possible, even restoration of body shape and movement potential for individuals with movement difficulties. And this is where some of those common myths come in. Body distortion is not inevitable. With the right postural approach, appropriate support and timely intervention, so identifying risk and being proactive, we can protect body shape. And that's a theme that we'll keep coming back to as we move through this session. Posture isn't just a mechanical issue. It's directly linked to a person's health, well-being and overall quality of life. And when body shape starts to change or collapse over time or become destructive, those effects aren't limited to how someone looks or sits. There are going to be physical consequences, but also psychological and emotional ones too, particularly when comfort, confidence and participation are effective. Poor postural care can in some cases have serious and even life-threatening consequences. We know, for example, that respiratory function is closely linked to posture and positioning, and people with learning disabilities, a significant proportion of premature deaths are related to respiratory issues. And posture itself is recognised as a contributory factor to that risk. The point here isn't to focus on statistics, but to recognise that posture underpins multiple body systems, and when posture deteriorates, tolerance reduces, function is compromised, and health risks increase over time. When someone is unable to maintain that upright, symmetrical sitting position, we know that overall health can decline. That can present in very practical, very familiar ways, with things like increased risk of pressure injuries or pressure ulcers, recurrent respiratory infections, choking or aspiration incidents, difficulties with swallowing, digestive problems, and in some cases a greater likelihood of hospital admission or surgical interventions as well. But the impact purely isn't physical. As I said, there are significant effects on psychological health and mental well-being too. When someone is no longer able to sit comfortably or safely, they're more likely to become confined to bed or to a limited environment. That restriction reduces opportunities for social interaction and functional engagement. It increases dependency on others and gradually can erode mood, motivation and confidence. So again, the issue isn't posture in isolation, it's how posture influences participation, health and quality of life over time. When someone sits, load has to be managed somewhere in a stable, aligned position. That load is shared across multiple body segments, but when posture deteriorates, load becomes concentrated. Pressure helps us detect that concentration, but it isn't the problem itself. The real issue is reduced sitting tolerance over time, discomfort, fatigue, loss of function, and eventually tissue damage. In practice, we usually see that end stage, that tissue damage, but the postural issues that led to it have often been present for much, much longer. So we need to be better at identifying those and using those risk management strategies. So what I want to do next is just quickly look and name what actually damage to the tissue may be and when tolerance is exceeded. This isn't pressure care training. We've done webinars around that. I think our last one in November was on that. So if you want access to that, again, that link is there on our YouTube channel as well. But just to keep the mechanisms clear, in the simplest of terms, A pressure injury is localized damage to the skin or the underlying tissue, usually over bony prominence, not always, but usually because there's less fat coverage there. The damage isn't caused by pressure alone. It's influenced by things like shear, friction, and microclimate. Shear is particularly damaging, so when the deeper tissues move, but the skin stays fixed. And we also now understand that tissue deformation, so the physical distortion of the cells, can cause damage very quickly, sometimes faster than reduced blood flow alone. Those risks are shaped by the intrinsic and the extrinsic factors. So intrinsic relate to the person, things like their diagnosis, their medication, their nutrition, their continence, whereas the extrinsic or external factors relate to the environment, things like temperature, the equipment selection, the support network, and how consistently strategies are implemented. And it's that interaction between posture, load, and those wider factors that determines tolerance in sitting. And that's why seating decisions can't be reduced to one feature or one risk score. From a mechanical perspective, even in optimal sitting position, that gold standard, hips and knees and ankles flexed, slight anterior tilt, which of course everyone, if we put the cameras on now, everyone I'm sure is sitting in that gold standard position. But even if we were, with everything equally distributed, we've still got 75% of our body weight going through our pelvis, through the buttocks and thighs. And we've quite shockingly still got around 20% going through our feet. So if pelvic alignment is compromised, somebody has a pelvic obliquity, for example, if foot support is inadequate, we've seen it before, I'm sure you've gone into environments where the foot plate has been removed or it's been used as a doorstop, or it's got missing, that load doesn't disappear, it just concentrates somewhere else through a very small area. Despite this real obvious correlation between posture and pressure, seating is still frequently under-prioritised compared to bed-based interventions. Risks are missed. These problems develop gradually, as I've mentioned earlier, and by the time they're visible, the complexity has increased significantly, which is why assessment, proactive positioning, and those early decisions makes sitting matter and is far more than what they're given credit for, basically. So how do we be proactive then? How do we identify some of those risk factors? Seated postures are uniquely risky, particularly for people with complex needs, because they combine prolonged exposure with limited opportunity to offload or adapt. So many individuals that we work with are unable to reposition or weight shift independently, maybe due to things like weakness, frailty, or motor impairment. That risk is compounded when cognition, sensation, or postural awareness are impaired, because that person might not simply recognise discomfort or be able to respond or act on it. As posture starts to deteriorate, things like that posterior pelvic tilt, sacral sitting, lateral leaning, pelvic asymmetry, the body adapts around that poor support, stability reduces, asymmetry increases, and load becomes concentrated rather than distributed. So systemic factors, so some of those intrinsic stuff as well, like malnutrition, hydration status, temperature regulation, further reduced tissue tolerance. That means that the body has less capacity to cope with that sustained load. And of course, it increases wider health vulnerabilities as well, including the physiological risks that we touched on earlier. So it's helpful to think about risk in sitting in three interacting layers. The intrinsic factors, the person themselves. Secondly, how those intrinsic factors influence mechanical presentation. So their preferred postures, their habitual postures, and how they present in sitting or lying, and whatever posture we're looking at throughout that 24 hours. And third, then the extrinsic factors, the seating environment, and how consistently strategies are implemented. So the risk is rarely about one factor. It arises from that interaction between the person, the posture, and the seating environment. And that's the interaction that we really need to assess and manage well. And once we've identified and understood an individual's risk factors, the next clinical question isn't what equipment do we need? We need to actually ask ourselves, does this level of risk warrant a postural assessment? Not everyone who sits needs a full specialist seating assessment, but when risk is elevated, through reduced movement or instability or asymmetry that have come up, reduced sit intolerance, a structured postural assessment becomes essential to inform safe and effective decisions. The purpose of assessment is to understand how the person manages load across that full 24 hours. Where is stability being lost and what support is actually needed to maintain their posture, their comfort and function over time. And once that understanding is clear, we can then start to think sensibly about support and subsequent seating, rather than reacting to problems after they've already developed. That true proactive approach to postural care. A thorough and systematic assessment is the cornerstone of effective specialist seating, but it's helpful to be clear about what we actually mean by assessment in this context. Postural assessment is about understanding the person, looking at body shape, alignment, movement, stability, tone, critical angles, how posture is influenced by health, function, daily life across that full 24 hours. It's where we build that picture of what is happening to the body, but also why is it happening. A seating assessment comes next. That's where we take what we've learned from the postural assessment and consider how the seating system, so the chair, the setup and the functions, need to respond to those findings. So it's important we have those findings before we then work in combination with the seating assessor to come up with that solution. Underpinning both is the information gathering. So it has two equally important components: history taking and physical assessment. Understanding the person's story, their routines and their priorities is just as important as what we observe physically when we get hands-on. So in simple terms, assessment comes first, understand the problem, and then seating follows as the response to that. When that order is clear, decisions become a bit more logical and a bit more effective. So the purpose of that assessment is to understand overall risk. That means understanding which factors are intrinsic to the person, which are external, how do they interact, and actually what can we influence. And it's not just assessing the person sitting in front of us, but their wider daily routine. And as I said, you'll have a copy to the presentation, so you can kind of go through these slides in your own time and understand in a bit more detail where that assessment criteria may be, what do we need to focus on, what information do we need to gather from that. And just to say as well, I mentioned about the scope of this training day. This isn't about kind of giving you those hands-on support, because we're obviously limited by time and by being virtual. So if that is something that you feel that you would like to work on a little bit more, that's where those clinical study days come in, to get a bit more hands-on look at those specific assessment techniques rather than the strategies and the frameworks that we're covering today. When we talk about assessment, and I mentioned kind of, holistic, proactive approach to postural care, that's all about that personalised care, prioritising the individual. This isn't a philosophical position, it's a practical one. If we prioritise the individual and take the time to understand their daily life, their routines and their priorities, many of those downstream decisions become much clearer and much simpler for us to make. Ultimately, what we're aiming for is compliance, because we can only achieve our clinical objectives if the care plan is actually followed. We can only protect posture if the person is able and willing to engage with that seating strategy. So that means grounding our seating decisions in the person's real life, matching chair functions to their abilities, their hobbies, their occupation, not just a diagnosis or their posture on the day of the assessment. Take the time to listen, empathise with challenges and involve the individual, and where appropriate, the caregivers as well, and we'll cover that a bit shortly, because having them as equal partners builds that rapport and trust, and that trust is what directly influences compliance and long-term outcomes. Once that overall picture is clear, the person, the risk, the support network and the environment, those assessment findings, we can start to think about what seating is actually trying to achieve. It isn't about fixing posture, it's about supporting posture over time. So at its core, good seating should promote stability without rigidity. We should have alignment without force. and comfort without compromising on function. And that balance, and again, we can't give you every answer here, we can only support where we can, but it is a fine balance. And if you are thinking that somebody is identifying with some of these risks, and the postural assessment has highlighted the need for a seating assessment, we can work with you to help you navigate that balance, understanding how to prioritise, and sometimes where we need to compromise as well to make sure that we are getting the most optimal outcomes for that individual. When we think about seating, these key seating principles, it's about supporting the body in a way that distributes load whilst maintaining their tolerance, but also allows them to engage with their day. So it has to be tailored to that individual risk. Should be supportive, given that stable base of support without restricting their movement. It also needs to be adaptable because needs change, as we know, across the day, but also long term as well. And it has to be aligned with daily life, not just, as I said, that assessment environment. It's also important, really, I guess, here to recognise that specialist seating is a medical device. Alongside the benefits, there are risks. Functions and features should be intentional. They should be used with a clear understanding of why they're being used and what they're trying to achieve, but also the precautions as well, and maybe when they shouldn't be used. But we'll touch upon that when we look at the chairs and we kind of go through some of those functions. These principles that we can see, in a way, they allow us to judge whether seating solution is appropriate, I guess, regardless of the chair itself. And then we have to define and often prioritise these as well to ensure we achieve those positive outcomes. For example, if an individual has been confined to bed for weeks or even months, maybe started through an illness or a hospital admission, and potentially now deconditioned with a high risk of pressure injury, is achieving perfect posture realistic? Actually, the most beneficial thing for them might be just getting out of bed in a fully supportive, not corrective seating surface for 20 minutes. That might make the world of difference to their well-being. So it is really important and really helpful to define and prioritise those principles as well, just to help with your seating provision. Once we've completed that comprehensive holistic assessment, we should have enough understanding then to start forming our interventions. That might include signposting, onward referral or medical review where maybe it's an outside our area of specialty, or where there may be more specialist support needed for particular areas, because it's all about being holistic. But from a seating perspective, that's where we can begin to translate assessment findings into selection decisions. And that's usually, as I said, working collaboratively with the seating provider and the seating assessor. It has to be person-centred. And as I said, that's not just a value statement. It's because we know that compliance underpins outcomes. If the seating strategy doesn't align with the individual's goals, their routines and priorities, it simply won't be used. And unused seating can't achieve clinical objectives. Chair selection is never one size fits all. At a minimum, the chair must be clinically appropriate for that person's risk level, their posture, their mobility and function and so on. It must be adjustable to accommodate changing needs and support participation. It should be supportive of repositioning strategies. We'll touch upon that in a bit, whether that's through independence, caregiver input or using the functions of the chair. And it must be appropriate for their seating tolerance as well. And lastly, it has to be aligned with the lifestyle goals and that whole care context. Getting the basics of the chair is really one of those foundations that can be most easily overlooked, but actually may have the greatest impact on safe and effective seating. So seat width, depth and height must be measured against the individual, not just assumed. Too wide and we encourage leaning, too deep and we can start seeing sacral sitting, too high and people might start sliding forward in the chair to get their feet on the floor to get that proprioceptive feedback. These are small mismatches, but they have disproportionate effects on posture and stability. A poor fit can increase those significant risks that we talk about, like shear, can reduce immersion and can undermine repositioning as well. Armrest height also matters more than we often give it credit for. When set correctly, armrests can support independent weight shifting and functional activity. They also need to be appropriately padded, maybe to protect skin integrity. The critical angles for sitting that I mentioned briefly need to be considered, because so when we talk about things like knee range of movement informing the leg rest angle, or hip range of movement informing the back angle, and how those functions can be used day to day, they will influence their postural security within the chair, their comfort, and how well they can maintain the position over time. Again, we've done a whole webinar on that topic, so it sounds like I'm going through this quite quickly, but I think it was maybe last September we done a full webinar on tilt, recline and elevate. So again, if that's something that you want to increase your knowledge on, then please check that out. It's worth remembering that a chair is only as good as how the person is positioned within it. So the setup must align with positioning and those moving and handling guidance as well. And in some cases, that might mean signposting for additional specialist input. And again, we can demonstrate some of these points shortly. Chairs must do more than hold the body. They've got to support that movement. Postural stability is what's critical here. When the trunk and pelvis are stable, proximal control allows that distal movement. So when the pelvis is secure, it means that the upper limbs are free from their load bearing role and they can engage in activity. You know, communication, engagement is an important part of that psychological aspect, but also if we encourage movement and activity, it means that we're protecting the body structure as well, because we're taking the joint through range, we're getting blood flow to those areas. When someone feels unstable, we can often see compensatory behaviours, so gripping the armrest or anchoring into the corners of the chair, slumping for security, trying to lower their centre of gravity. Those strategies, of course, reduce function, they increase asymmetry and ultimately increase that risk of seat intolerance that we spoke about. So movement matters, taking the joint through range, changing position, enabling activity to support tissue health, circulation and that tolerance over time. So as I said, to maintain that stability, postural support is a key element. And again, when we look through the chairs, you can see how different aspects down to the cushion itself, getting those chair measurements right, maybe then moving our way up to ramped bases or contoured cushions, making sure the trunk support is there that is adequate, but also allows for some active engagement as well. And then onto things like specific functions like tilt and space, if it's appropriate. So I won't spend too much on this slide because, again, it'd be better for you to see this visually. But if we are then identifying risk, we're understanding that risk, we're thinking that tilt in space or back angle recline or leg rest elevation or negative leg rest elevation may be indicated. We also then have to be aware of the benefits, but also the risks of these, because as I said, it's a medical device, and if some functions aren't used appropriately, they can actually increase shear, increase friction and increase the risk of falls. For example, if we skip a step and we don't look at pelvic stability and somebody goes into that sacral sit-in or even into those strong extensor thrusts, and then we decide to put a back angle recline on, we're opening up the hip angle, we see in tone increase, those abnormal movement patterns increasing, and we then obviously have the risk then of the friction and the shear and falling out of the chair. So there has to be that balance between, is it suitable for this person? And again, we can help with that. So the $1 million question, I guess, what is good sitting posture? As I kind of said throughout this presentation, it isn't about holding someone still or achieving a textbook position. It's about creating a posture that's stable, comfortable, but sustainable over time. At a baseline, we're looking for symmetrical support where possible, midline alignment, and a pelvis that feels secure within the chair. The trunk should be supported without being restricted, and the head position so that the person can see, communicate, and engage with the environment. The upper limb should be free for activity rather than being used to hold the body upright. There should only be about 2% of the body weight going through the arms of the chair. The feet should be well supported to contribute to that overall stability through that proprioceptive feedback. This is a reference point, of course, not a rigid goal. In complex cases, I know the perfect alignment isn't going to be achievable, and that's okay. What matters is that the posture we support is the best achievable posture for that person, given their needs, their risks and their goals. So going back to those principles, defining them and prioritising and being okay with a compromise at some point. That reference helps us to judge whether seating decisions are supporting stability and function or whether compensations are starting to creep in. When posture isn't adequately supported, gravity will always take the lead. In sitting, that often shows with things like sacral sitting, so that posterior pelvic tilt, lateral leaning, so slumping to one side. You get this sort of pelvic obliquity happening where one side of the pelvis is higher than the other, sometimes a rotation as part of that. These aren't random, they're predictable adaptations to poor stability and inadequate support. As gravity pulls that person and their body structure downwards, asymmetry increases. The load shifts away from shared surfaces, and when we get these concentrated areas, stability reduces, shear increases, and then the body starts to adapt around the chair rather than being supported by it. And over time, those destructive positions become the person's default. And then that's sadly where assumptions creep in. That's how they've always been. How about we step in, we challenge, actually, is there something I can do? It makes it harder to correct. It's more difficult to tolerate, but it's worth the investment from us to challenge that and try and break that cycle. In contrast, this is often what we describe as optimum positioning. And as I said, being upfront here isn't always achievable, particularly in complex individuals, and it's not a rigid target, but certainly not something that we force, but something we strive towards. A good clinical reference point, but just being sure that we are getting the person at the heart and seeing what the most optimum position for them is. As I've said, the chair is only as good as how it's used going forward. Even the best seating system with the most advanced cushion, the most precisely set up chair, it cannot eliminate that need for movement. And I can't emphasize this enough. This isn't about achieving one perfect posture and holding it. It's about supporting a realistic, achievable positioning strategy over time. So if somebody is identified as at risk, if you are doing your postural assessment, that then has to inform a timetable of sorts, a plan of action across that 24-hour to make sure that we are getting a change of position regularly. Some people can tolerate short periods of sitting, others can tolerate longer. Any form of postural care has to be a gradual introduction, especially if they are being confined to a destructive position for a long period of time. It has to be gradual, a gentle approach to it. And making sure that we have those touch points and review points to gradually adapt and change and hopefully improve as we work through it. There's no universal rule for this. So again, we can work by case basis and support you through that. Holistic approach I've mentioned as well. I've spoken about keeping the person at the centre, but just be mindful that when we talk about person-centred, something that might be a strong element of that is the caregiver, the support network. Especially if we do rely on them, if they are the ones actually following the care plan and implementing that. So where possible, engage them, understand their goals and preferences and their barriers as well, to make sure that we can better understand daily life and caregiver input to increase that compliance and reduce dependency. So that's not just helpful for the individual, but also reduces the carer effort and the load and the responsibility that falls on them as well. So we need to think about how they fit into that 24/7 and give them the strategies as well to be able to identify risk. We cannot be there 24/7, especially if you don't hold a caseload and you discharge. The support network is vital. So we need to give them the tools to be able to know what might be risky. Is there a new change that may need to be addressed? How to reposition and who do we reach out to get that support? And that would inform a really important part of the care plan, which consolidates all our information. So again, all that hard work we do has to end in that care plan to make sure that everything is implemented, because once we leave that environment, it's all down to how that chair is being used or any piece of postural care equipment. So the assessment doesn't end at prescription. We need that care plan and a robust review process. So even if you discharge, that care plan is your review process strategy. There has to be factors on there, red flags to look out for, a checklist that if you see a new red area, if they're fatiguing more quickly, if they're asking to go back to bed more often, if there's a change in behaviour, this may warrant the need for a review. So please contact us on for a re-referral. And that kind of just gives you that robust plan in place, even if we're discharging, if there's no set plan in place. Where possible, having annual reviews. I mean, I come from learning disabilities where we were very fortunate to have the resources to be able to have annual reviews where we had a spreadsheet and people were called upon to come in and have those annual reviews. So we had that robust process in place. But sometimes we need to think outside of the box to do that. Images can be really powerful where possible, photographs of what the ideal optimum position is. And if anything changes, that may be a good point to think, actually, do we need to review this sit-in? There may be some new neurological impairment that's masked by their diagnosis. That again is really vital for us to catch early and be proactive. So some key takeaways then before we kind of consolidate this. Sit-in is a postural demand, not a rest position. The risk accumulates over time. Posture determines the load distribution, which determines their overall tolerance. Pressure is the signal of that. It's not the cause. Postural decisions come first. And effective seating starts with that comprehensive assessment, not the equipment. So make sure we work it that way around. Stability enables movement, and it's that movement that protects health and function. Getting the basics of setup right has a disproportionate clinical impact and actually something that gets overlooked. So invest in that time in the chair setup and handing over, if we need to caregivers on how to make those adjustments themselves. Dynamic functions can support or undermine outcomes depending on how they're used. And just remember, there's no perfect posture, only the best achievable possible for that individual, but repositioning remains essential. No chair can replace that movement. So far, a deliberate focus on how to think about sit-in rather than jumping straight to equipment. What we want to do now is to just show how the frameworks that we've covered are applied in practice. So rather than talking through them, hopefully you can see us back on the screen. We'll just kind of look at some of those practical seating strategies, run through what seating may be, those of you who may be completely new to specialist seating.
So we've got 3 chairs from the range to illustrate some of the theory that Rebecca's been speaking about this afternoon. Mild to moderate postural care with the multi-adjust, more complex with the Smart Seat Pro, and a bit of a niche product with the Alpha Care. Just work through some of the features of the multi-adjust. Chair is a tilt in space chair with back angle recline. I'm going to whiz through these things because Rebecca's not left me a lot of time.
I'm sorry, Les, I talk a lot.
So tilt in space, just briefly, it's managing to tilt the chair back and keeping the hip angle constant. The hip angle doesn't change. The back and the seat move together in unison. So once we've got that pelvic stability, we don't want to allow the pelvis to tilt back unless we're accommodating somebody's fixed posture.
Yeah, so when we said about appropriate use of functions, if you're needing the functions to help with things like pressure care or repositioning or stability, tilt is probably the function to go for before considering recline, as long as the hip angle is well supported. Covering
back a little bit on Rebecca's presentation about caregiver input, we've tried to clearly label the movements and adjustments on the chair, plus all the adjustments and movements are tool-free. So an example of that will be the labeling of tilt in space and back angle recline. On the left here, we have back angle recline. On the right, tilt in space. Back angle recline is a double lock system. So I don't know if you can see that very well there against my hand. To activate back angle recline, if I squeeze it, nothing happens. I need to take the lock off, squeeze and adjust, and you'll hear it click, locking back into place. Foot plates and leg rest, vital components of any specialist seating system. Elevating leg rest.
Sorry, let me take it back. I'm not sure if it's on the screen.
Take it back a little bit. So with the leg rest, it'll elevate. It'll also go down into a negative angle, helping to accommodate those people with fixed range of movement at the knee. We can also extend the leg rest. We can angle the foot plate as well. Seat width adjustment built into the chair. The arm at a range of 40 centimeters to 55. You want to demonstrate, Rebecca,
Yeah.
the dangers of getting this wrong? Also going to adjust the seat depth while I'm here as well. Show you what I'm doing. If we can see the lever at the back, if I just twist the lever down from the back towards me to adjust the seat depth of the chair. Jump in.
Yeah. Tilt it back up for me.
No.
Thank you. Yeah.
So if I get the seat depth, seat width wrong,
I don't know if you can see.
black against black.
Yeah, I should wear pink trousers next time. If you see about the gap that's happening there, we naturally seek that proprioceptive feedback. So if we're suddenly feeling unstable or if our damage to our body system creates that instability, we can see people can see that rotation happening, that pelvic obliquity happening, just to get that stability and that feedback to support us and feel that we are steady and secure within the chair. The same with seat depth again. I mean, it's not hard for me to have the seat depth too wrong.
Shall I just twist the chair around?
Yeah, but I can't physically bend my knees over the edge of the chair. So to be able to position my feet at the moment and not get that stability through my feet, I've got increased pressure going through because that 19% that we spoke about is going through the buttocks and the thighs. So to be able to get that stability, it forces me to go into that posterior tilt, which then has an impact on everything else, on the spine, on the head position, and then creates, pressure through the sacrum, unequal loading. And that's simply, I don't have any damage to my body systems, but simply from the setup of the chair, it's created these significant postural abnormalities just from the setup of the chair. So it's really important, not only in individualised prescriptions, but multi-user environments as well, that the caregivers know how to adjust between each user.
The detail is really important, and as part of the service is actually coming along, setting the chair up for somebody to use. Back angle recline. It's what it says on the tin, is the back reclining in isolation to the rest of the chair, which can be essential for some people, but can also bring us some challenges in managing how we use that. If we open up the hip angle, indeed, we can destabilize the pelvis, which will make it easier for somebody to slip down that chair. So we need to be very careful on how we achieve or how we set that angle up for somebody.
Again, if this is new terminology to you, we have a webinar specifically on tilt, elevate and recline that kind of runs through more of the precautions and the indications for it. That's something that you need. We spoke a lot about, postural stability and trunk alignment, one of those effects of gravity. Back support is probably another element of the chairs that is really critical. As part of your assessment process, working through pelvis, spine, having a look ahead and trunk alignment, which we cover, on clinical study days, but, different trunk supports. And it's really important to understand
what we have here is a contoured back. This tends to prompt somebody to sit in that midline position. If we need to up the level of support, we can add adjustable laterals.
Like a magician show.
You can add an adjustable lateral onto the back of the chair. We'd swap the contoured back out from the flat back, and we'd use an adjustable lateral so we could position that more accurately on the chair.
Yeah, when we said about kind of the functions and accessories and understanding the benefits and the risks, anything additional to the chair, like the external laterals, pommels, positioning aids, again, the medical devices, there are now, you know, ISO standards, international standards have been accepted around things like positioning aids. So it's just being mindful that over prescribing as well. If somebody doesn't need it, then simply don't put it on the chair. It's just something that can be used inappropriately. External laterals and back angle recline together, particularly if you are thinking the back angle recline is suitable, then external laterals may not be the best option for that, just because of the positioning. When you go into recline, the laterals move away from where they need to be, and then when we come back up to upright, we're relying on the individual to be able to reposition themselves, and if they could do that, they probably wouldn't have the laterals in place. So again, understanding the functions, appreciating and respecting the benefits, but also the risks as well.
So that's a whistle-stop tour of the multi-adjust. We do the multi-adjust advance, plus a small version of the multi-adjust as well. You can see it in the background there when Rebecca was talking. You could see that I was just moving and repositioning different back sections onto the chair. It's very modular design. It's a multi-adjust chair for a multi-population setting. So it can be changed very, very easily. So moving up the range in terms of postural care complexity, move on to the SmartSeat Pro. Again, a tilt and space chair with back angle recline, operated in much the same way as the multi-adjust. We're anticipating working with more complex clients when we use a chair like this. So tilt and space, as an example, is monitored and recorded on this chair and measured with a gauge just here, so we can tell at what angle the chair is being used at, because for some clients that can be essential. You know, think of swallow, chest infection, choking. We need to monitor how that is being used, and we can include that as part of the care plan so far. Meal times, it could be 0 degrees. After lunch, when somebody's slightly fatigued, 10 degrees. Never want to go more than 20 degrees because it causes a problem for choke and swallow. So you can see we're slightly getting more complex ways in which we provide postural care with this kind of product.
One thing I didn't mention is probably worth touching on when you talk about postural care and the foundations. It's actually a really important one, because I know a lot of you may work in isolation, especially within maybe community settings, but I would really advocate to spend the time trying to find out who some local support would be, even if it's not official referrals. Again, it obviously depends on the individual, what kind of pathway they fall under, whether you work in general community or old age or neuro, and it changes between NHS and social services, or everywhere we travel around the country has a different pathway or protocol in place. But invest in the time to find out who your local speech and language therapy support may be, the OT and physio joint working if possible, manual handling advisors. Is there a spasticity management clinic? Does that fall under rehab medicine or neuro services? Orthotics, just invest in that time to see who maybe, or tissue viability, you know, who are those local contacts in your area that you can lean on for some support or peer review, or hopefully official referrals and signposting, because postural care, to be holistic, it has to be multidisciplinary. We can't be, you know, the master of everything. Even though we might be expected to be at times, there are going to be certain things outside of our area expertise, especially when we talk about things like that, as specific as care planning around tilt angles. We need speech and language therapy involved if somebody has swallow dysfunction. As
a seating assessor, I'm just part of a multidisciplinary team. You know, and you can't give us too much information about a client's needs. It may seem trivial, but it could be the thing that makes the massive difference for somebody. So moving up the chair, first of all, below the arms, chair is very similar to the multi-adjust. So you've got seat width, seat depth adjustment, adjusts in similar way. Just twist the lever, spin that back. I've got adjustable laterals that can be set at any point in the back of the chair. So I've got a range of movement there. you'll notice it's an ergonomic shape as well. So it kind of grips. We do these in a flip away version as well now. The key feature of the chair is the multi-adjustable back. 4 sections all adjusted in a similar manner. All tool free again. So if I have somebody a little bit taller, I may need to be accommodating somebody with a fixed posture. I may have somebody who's kyphotic. Sometimes it's difficult to imagine that a person would sit in a chair like this, but it's just an example of how configurable and how adjustable the chair is.
It's actually another, going back to those foundations again, how important assessment is, but also how important defining the seating principles are, because what we don't want to do, especially for the type of individual who's got this chair, they more than likely have a wheelchair, sometimes maybe even a bespoke wheelchair, like a contour back or a moulded insert. We don't want to be replicating that seated position. As they said, it's all about active movement, encouraging a change of position. We don't want to replicate that. So again, it's that fine balance between what do we really want to achieve from specialist seating? Is this just an opportunity for comfort, a bit more flexibility? Are we compromising on that static rigidity because we want to allow some freedom of movement, allow some time for the tissues to reset, to get that blood flow? So those key principles, those foundations, really important part there with complex individuals.
That's a real, again, a whistle-stop tour for the SmartSeat Pro. Both chairs, the multi-adjust and the Pro, can be powered. You can have powered tilt, powered leg rest, powered back angle recline. When we talk about power, though, we tend to go for a manual back angle recline, and we call that option Pro Control.
Not because we have trust issues.
No, not because we've got trust issues at all. There's also a feature across the range called auto tilt, which is a regulated motion. So the chair can be programmed to operate through its range of tilt and space over a given period of time as well.
Just keep that independence at home, reduces care calls and the dependency if somebody wants to be able to integrate that into home life without the need to get out of the chair, so they can change the position, get blood flow without having to leave the chair.
That's the SmartSeat Pro. Very, very quick overview of that chair. And finally, we have a chair called the Alpha Care. What this chair is all about really is helping them manage movement, and in particular uncontrolled career movement. The main feature of the chair, or a key feature of the chair, is the way that the back and the seat work in conjunction. So I don't like to use the word recline. It seems to be something we avoid whenever possible. But as this chair reclines, the seat base drops.
So as we get,
difficult to see.
as we get around 30 degrees of recline, you get 15 degrees of drop on the base.
So what we're doing, we're using gravity now to help control those involuntary career movements. I mean, when we were designing the chair, the kind of the working title was the Huntington's chair. So if you ever worked with a Huntington's client with a lot of involuntary severe career movements, that's who the chair's aimed at. With that comes a certain element of compromise. We have a slight contoured back because, basically this style of lateral isn't going to work with somebody with a lot of involuntary career movement.
Especially with injury and stuff as well. There's obviously a lower chair, so to lower the centre of gravity to get that stability, but then obviously this compromise then depends on their mobility levels and how ambulant they're expected to be.
Comes with a block leg rest as well.
A sliding foot plate, so there was some manoeuvrability needed to protect the feet and to get the feet grounded. But this kind of doesn't fall into mild, moderate, complex, because you could have a mild postural need because they're very active, but with a complex seating needs. So it's more of a specialised support with very niche. The
centre of gravity of the chair is quite low as well, so it avoids the risk of possibly tipping the chair. It's very strong and robust. We're looking at the typical client transferring into the chair. Put the brake on. Back. So they can be coming back into the chair and they're going to be falling into the chair. So very padded, very strong.
We've spoken a lot about individuals who, with severely reduced sitting tolerance, those who may be confined to their bed for a period of time. There is another chair in the range called the Air Comfort. Again, doesn't fall into a particular category, but it's a specialised need for people, kind of like a transitional chair, to be able to gradually get someone from a lying position to hopefully tolerate a sitting position. And again, that's just sits outside, so it's not a chair you might come across because it doesn't really sit within the mild, moderate complex. Yeah.
That's a very, very quick overview of the chairs that we have with us today. If you need to see the chairs in a bit more detail, if you drop us a line, we'd quite happily bring the chairs out to you and your team to look at. Obviously, there's a seating assessment need, drop us a line.
I can't see any questions. I think Kiwi's maybe been on top of them.
Just going to have a quick look at the Q&A. If there's something that we've missed, please feel free to email us.
Okay, we've got a question here. Can the armrest angle on the Smart Pro to accommodate fixed abduction? And can the multi-adjust be used? Okay, so let's do that one first. Armrest angle for fixed abduction. So yeah, so they can, so the armrests can be adjusted, so it's independent left to right and front to back. So it is an element. So up and down, but also left to right as well. So if you think about somebody now with like wind sweeping, there's an element there of.
See if I can show you on the multi-adjust.
Is an element.
We're doing that with the Smart Seat Pro as well.
If you talk extreme fixed abduction, you know, if you've kind of got that frog-legged potential or extreme wind sweeping and you need more of an angle change, then you can have infills as well. You know, as a tailored solution, if we needed to kind of sculpt the arm rest a little bit more, there is that option.
That's right. We've not talked about tailored solutions. I mean, everything you've seen with me today is a kind of an off-the-shelf component of a Careflex chair, but we also have the capability to make bespoke components for the chair as well.
There's another question here about the multi-adjust, about its use with stand aids. Does the footplate fold up?
Yes.
There are different elements of the multi-adjust that has been considered specifically for stand aids, so being able to have that negative angle to try and get better foot placement. The flip-up footplate, of course, but also the chamfered arms. So you can see the shape of the arms are chamfered. So if you're using something like a steady, hopefully allows for a bit more space for the paddles to be able to then get the bottom and the pelvis seated further back within the chair. Again, it all comes down to trial, depending on specific stand aid, but also the person's ability to position themselves as well. There are limitations, as we know, with any kind of transfers. So definitely worth a trial to see if it matches up. I think that's all the questions. Yeah, I think so.
As I said, if you've got any more questions, please feel free to drop us a line. We're just going to draw the presentation to an end. I hope you found it interesting and informative. Is there anything from you, Rebecca?
Oh, I think one more question just came through. Any future plans to design flip-away laterals?
Yes, we've got flip-away laterals for both chairs.
It's exciting.
That's our flip-away lateral.
Really good question, actually, because when we talk about, you know, caregivers, following support plans and how important it is to position somebody in the chairs. Obviously, the chair's only as good as how they position. Sometimes external laterals, especially if they're removed from the chair, not being put back in the right place, not at the right angle. But the flip away allows them to move out of the way for transfers, especially so you don't get the sling stuck. And you can then position the trunk and align the trunk, and then they return to that fixed position. So yeah, good question. We didn't mention that. I think no more comes through. Yeah, no, I think that's it. Brilliant. Thank you so much for joining us. I know it was a lot of information, but we really this wasn't about really going back to the basics. It was just kind of refreshing the foundations, understanding the benefits, but also the risks, and how that then informs, because there's all this thought that has to go into it. It's not just about the assessment of its prescription to get seating and any kind of postural care right. We have to think about that holistic view, and those strategies and frameworks that are in place to identify risk and make sure that it's not just a static solution. We need to think about that tolerance through over time, predict in some way without assuming, so challenge those assumptions, break those cycles. So yeah, any other questions that come up, you've got our contact details. You'll get a copy of the presentation shortly, either today or tomorrow. And yeah, join us for the next webinar.
Yeah, keep an eye out.
Yeah, thank you very much.
Okay, thank you. Bye-bye.
Bye.
Bye.